Hey folks, today I want to chat about why or how a surgery prelim has the potential, has the opportunity to make you a better radiologist. So I started off as internal medicine, as I mentioned, applied to ortho, didn't match. But the important part for this video is I switched to a surgery prelim. And of course, you guys have all done internal medicine rotation. You know that they tell you we should always look at our own scans. We shouldn't just read the radiology report blindly. But I mean, in reality, that the fact that internal medicine is not as rushed, the fact that you can show up at 6 a.m. to pre-round, pre-chart, you can look at the scan and you can read the report, and then you're presenting to your attending. They care more about history, physical exam, social situation, like all this other stuff. And the imaging is important, but it's not the guidance for management in internal medicine. And so you just have so much more cushion to not even read the scan if you don't want to. There's no pressure for you to learn how to read scans in real time. And I'm going to talk about that a little later. But the number one reason that a surgery prelim or any surgeon builds radiology skill as part of the job is, it's no secret that surgeons, they have to look at their own scans before they're the ones who's going to cut someone open. They have to look and see the scan. Of course, the radiology report is invaluable. I mean, they're getting that, they're reading it, they're even calling the radiologist, but we're looking at our own scans, and then we're going inside the body and we're seeing that hematoma, that liver laceration, that mesenteric ischemia, that SMA clot. I've seen those things on the scan and then seen them in the real life. And even for non-trauma stuff, non-urgent stuff, like when I was on breast surgery, we see a breast mass on X-ray and then on MRI, and the radiology describes it, this, that, and then I'm going into the operating room and I'm seeing that. I'm seeing those margins or how much around that mass, how much tissue we're taking out. And then when that tissue comes out of the body, we can, hold it up, feel it, palpate it, look, and then that real experience of seeing what's on the scan with your own two eyes afterwards, it helps you remember things. It helps you see, like, if this is on a scan, that's like how big it is on a scan, and then comparing it to real life to when you actually see it. I mean, it changes the game. It's not something, it's indispensable at the end of the day. So going inside the body, and because you're the one going inside the body, you're reading that scan with that plan of, I'm going to actually be inside the body now. So the scan is like, it goes hand in hand with surgery. I think more so than in internal medicine. Of course, there's exceptions, but imaging for surgery, it goes hand in hand. The other thing is now, when you're on call for internal medicine, it's totally different than when you're on call for surgery. So let's say a patient comes into the ED with like COPD or an MI, for example. The ED can start medications and then they consult internal medicine to take over. The ED can't operate. They can't start the surgery for you, okay? And the diagnoses that surgeons get consulted for are not as clear-cut as in internal medicine. So when I get a consult and I have to come to the ED for a small bowel obstruction, for trauma and bleeding in the belly, for perforated appendicitis, okay? I go see the patient and I have to make a decision quickly about, do I need to call my attending and wake them up if it's 2 a.m.? Or do I need to just bring my senior down right away? Or do I need to put in a case request to the OR? How am I going to do that if I'm waiting for rounds or if I'm waiting for the radiologist to read it? I have to make that decision in real time. So, and you can say, well, I'm still an intern. Maybe I'm not as good. I might be wrong. I'll give you that. But there's pressure on me indisputably when I see a sick patient to order a scan and to wait there in the room as soon as that scan is done. If it's a portable X-ray I'm talking about, if it's a CT scan, to call radiology, get it run faster, get it up the chain, move it forward. And then as soon as the images come out, I'm looking at that scan, okay? And so, I mean, I can give you an example. like let's say we have a post-surgical patient who was operated on, they had a colostomy done, and now they just have crazy belly pain. Okay, so I'm going into the room, and I'm obviously examining their belly, and if it's suspicious, I'm getting CBC, CMP, VBG with lactate, all the things that internal medicine resident would know to get. Okay, and I'm getting a portable upright chest X-ray to look for free air under the belly. I'm getting a KUB portable, and I'm reading that in real time, and I'm calling my attending and saying, hey, this is what I see. We don't need to operate. This is what I see. I think this, you need to come in and evaluate this patient, take them to the OR. And this has happened before. And there is more than once where I've called my attending and I said, not more than once, but it has happened where I was wrong. They obviously going to look at the scan, themselves. But there is this real-time pressure, and that's never going to go away. The other thing is, even for smaller things, like let's say I pull a chest tube, or a patient comes in and they need a chest tube. I'm getting a post-pull or pre-pulse X-ray to look, and maybe I caused a pneumothorax when I pulled the chest tube because I didn't use proper technique. Well then, I'm the one reading that. I'm seeing it, and I'm remembering now what it looks like and what a subtle pneumothorax looks like too, because I caused it. This hasn't happened, but it can. It's a complication of chest tube pulls, something that we're trained to look at. The other thing, of course, is as a radiologist, you might do a bunch of procedures. You might go into interventional. You might go into neurointerventional. And radiology, what I love about it, it's an expanding field, especially with interventions. So learning to suture, learning to use a scalpel, learning to cut, that stuff is hard. I've been berated for my skills, and I've had to improve them in real time. It's not like when you miss a physical exam finding and then your attending internal medicine's catches in and says your physical exam needs to improve. It's like, I cut this skin open. I cut open this belly. My surgeon and the attending surgeon is giving me real-time feedback on how to hold my hand, where to place my knife, my body posture, etc., etc. And so I'm getting real-time feedback on anything that's going to help me to be an interventionalist if that's the path I choose. The other thing is, this somewhat applies to internal medicine, but I think it's more intimate in surgery, is that you deal with all the specialties. And just like a radiologist, that's what radiologists do. They deal with all the specialties, because almost all specialties want imaging. But I'm not working with nephrology just by consulting them. I'm not working with urology just by consulting them. No, there's times where I'm working with urology or plastics in the room because we're operating on the same patient, or with cardiothoracic surgery because we're operating on the same patient. And so that kind of more intimate relationship where you're understanding other specialties more and more, I think helps you to be a better radiologist. So, in summary, it's really the pressure of surgery, the need to evaluate real-time imaging, and the opportunity to go into the body that, as a surgery prelim, will help you to be a better radiologist if you choose to take advantage of these opportunities.